A 68-year-old woman comes to the office due to a burning sensation in her chest and throat for the past 2 weeks. Associated symptoms include trouble swallowing. Medical history is significant for osteoporosis. Drug of choice in osteoporosis, bisphosphonates. You got the answer. She has no known drug allergies, smoked half a pack cigarettes, does not use alcohol. Everything else hardly matters because the medication responsible for this patient penetration also which are the following side effects. So, this is a clear case of medication-induced esophagitis. This you know. So, what are the medications that are associated with esophagitis? You should just know tetracyclines, aspirin, and many non-steroidal anti-inflammatory drugs, bisphosphonates, alendronate, risedronate, others, potassium chloride, and iron. So, moving on to the options now. Bisphosphonates are associated with osteonecrosis of the jaw, mandible or maxilla, and atypical bone fractures, that is stress fractures of the subtrochanteric zone and femoral shaft. Subtrochanteric zone and femoral shaft. The precise pathophysiology is still debated and may vary, but proposed mechanism include suppression of bone remodeling, impaired healing of microfractures, and decreased angiogenesis. Now let us discuss why the options are not correct. Choice A, chronic kidney medication induced nephropathy can be due to interstitial nephritis. Medication induced nephropathy can be due to interstitial nephritis. Or what I'll do, I'll be discussing this option A at length. This can be due to interstitial nephritis. That is attributed to which drug? Yes, very good. Excellent. If you answered cyclosporin, bingo. Cyclosporin is an immunomodulator. Then it can be crystal nephropathy. Crystal nephropathy, acyclovir. Acyclovir. Then renal vasoconstriction. Renal vasoconstriction, amphotericin B. Non-steroidal anti-inflammatory drugs, or it can be due to tubular injury. Tubular injury, aminoglycosides. Tubular injury can be attributed to aminoglycosides. Bisphosphonates are eliminated by the kidney and should be used with caution in patients with chronic kidney disease but do not have substantial nephrotoxicity. Then, choice B. Bisphosphonates decrease bone resorption, thus lowering serum calcium level. They decrease bone resorption, therefore lowering the serum calcium levels in the blood. They are sometimes used in the treatment of hypercalcemia of malignancy, if you remember. Hypercalcemia of malignancy. Then, venous thromboembolism. It is a recognized complication of, yes, what? Excellent. Selective estrogen receptors modulators like raloxifene. But these medications do not cause esophagitis. Bisphosphonates do not appreciably increase the risk of thromboembolism also. Bisphosphonates do not increase the risk of thromboembolism. Then finally, last but not the least, choice E, vitamin B12 deficiency can be seen in long-term which, yes, proton pump inhibitor. Very good, excellent. Like omeprazole, lansoprazole, anything which has a prazole, pantoprazole, esomeprazole, due to decreased, this is important, due to decreased acid dependent cleavage of vitamin B12. Acid dependent cleavage, when we take food, then there is acid dependent cleavage of vitamin B12 from dietary proteins. From the dietary proteins. But this does not occur when we take proton pump inhibitors because obviously acid is decreased. Although proton pump inhibitors may be taken by patients with bisphosphonate induced esophagitis, bisphosphonates do not affect vitamin B12 metabolism. They do not affect vitamin B12 metabolism. Fine. Bye.